Dude, I'm watching the Star Wars movie right now, and I'm not gonna lie, they're pretty good.
Joey Giuliani. All right, thank you. All right, sorry, my computer crashed. So a little bit of a delay, but we still can make up some time here. Let me share a screen. Yeah, I'm good. Okay, everybody can see that? Okay. First things first, let's talk about your exam on Tuesday. So Tuesday's exam 2, it'll be worth 35% of your grade. It'll be about 40 questions, mostly multiple choice, some true and false. And there's going to be a couple diagrams on there where you need to identify the congenital defect by looking at it. There shouldn't be any calculations. So we're going to cover ASDs, BSDs, AV canal, coarctation of the aorta, patent ductus arteriosus, congenital aortic stenosis, congenital mitral valve stenosis. And we'll start off today's lecture by going over congenital coronary anomalies. And then after that, we'll just kind of do a little bit of a recap on pediatric perfusion techniques, and we'll talk about some acyanotic considerations. Any questions on the exam? It'll be on Respondus, and you know, the goal is to have it from 4 p.m. to 6 p.m. If there's any modifications, we can make that as well. But it should be pretty standard and typical of how I do my exams. All right, no questions. I'll start with the last part of Tuesday's lecture. We ended talking with congenital mitral valve abnormalities. So we're going to move on to congenital coronary anomalies. The incidence of coronary anomalies, congenital coronary anomalies are very low. So it's been reported around 1% of patients undergoing angiograms, and about 0.3% of patients undergoing autopsies have been shown to have coronary anomalies. The general categories of coronary anomalies can be classified based on the origin of where the abnormal coronary artery is arising. So usually where it arises from the aorta, or sometimes it'll arise from the pulmonary artery, actually. That kind of ultimately classifies it. Your book highlights 2 relevant coronary anomalies, so that's pretty much what we're going to talk about. But there's many different types of coronary anomalies, but there's 2 main ones. And anytime there's an anomalous coronary, it's going to carry a risk of sudden cardiac death in all groups. So here's the 2 clinically relevant coronary anomalies that your book highlights. We're going to talk about Al-Kappa and ALMKA. So Al-Kappa stands for anomalous left coronary artery arising from the pulmonary artery. So basically it's an anomalous coronary that is instead of coming from the aortic root, it's actually coming from the pulmonary artery. That's called Al-Kappa. The second one is ALMKA, which is anomalous left main coronary artery arising from the right coronary sinus with its course between the aorta and pulmonary artery. So that's ALMKA, and the first one was Al-Kappa. And there's other permutations in terms of how a coronary artery can be congenitally anomalous. You can have an anomalous right coronary artery coming from the left sinus of Valsalva. Some patients can be born with a single coronary artery. Your left and right coronaries arising from the posterior non-coronary cusp of the sinus of Valsalva. And you can have pulmonary origin of the RCA. So there's different permutations, but I would say Al-Kappa and ALMKA are the ones that we see the most, even though they are rare. Al-Kappa, anomalous left coronary artery arising from the pulmonary artery, is rare. It's 1 in 300,000 infants, comprises about 0.2% of all congenital coronary anomalies, congenital anomalies, can cause myocardial ischemia and infarction within the first few weeks or months after birth. And because you have a left coronary artery coming off the PA, very common to have ventricular dysfunction and heart failure. So how do we know if a baby's born with an anomalous left coronary artery arising from the PA? Well, this baby will have chest pain. This baby will have angina. How do we know if a baby has angina? Can they tell you my chest hurts? No, I mean, so ultimately they're going to be an extremely fussy baby. They're going to be in pain. They're probably going to be in more pain during any type of exertion. So ultimately, a baby crying a lot, you're not always going to know what's going on. So ultimately, a cath is what's going to verify it. Believe it or not, sometimes this type of defect can go undiagnosed until the teenage years. I haven't done many of these cases, but the last case I did was a teenager. I think it was around a 16-year-old that wasn't diagnosed with Al-Kappa until the 16-year-old was playing sports and getting winded playing volleyball. And then they did a cath and noticed, oh, well, you have a left main coming off the PA. So obviously a good portion of the heart was being perfused with desaturated blood. So ultimately a cath is what's going to verify it. You may see a patient may have systolic murmurs. continuous murmur from the flow of the anomalous coronary artery. There could be a gallop associated with the LV dysfunction that's happening. You can have pulmonary edema, but it's pretty amazing that someone born with an anomalous left coronary can actually go into their teenage years before really being fully diagnosed. So how do you think the patient I had was able to go into the teenage years? What do you think happened physiologically that maybe allowed this patient to go that long?
They were right dominant.
Okay, well, I would say being right dominant. Okay, what percentage of patients are right dominant? And for the sake of the class, Mike, what is right dominance?
Let's see if I can get these right. I think it was around 15% of patients were right dominant. And what it means is that the posterior side of the heart is perfused by vasculature that stems off of the right artery, not the left artery.
I agree with mostly everything you said, except the percentages. So 85% of patients are right dominant.
I had the split right, just the wrong way.
You did right. And I would say for that patient to live till 16 before it got diagnosed, I would almost say for certain that patient was right dominant. So right dominance means that the posterior descending artery, remember that's the artery that comes off. I'm on Julie's computer, so bear with me. I'll just stick to a laser pointer right now. This isn't the best depiction of the coronaries because you can't really see the backside of the heart. But the posterior descending artery in 85% of patients that are right dominant arises from the right coronary artery. And as we know, the posterior descending artery is the artery that goes down the back side of the heart, the posterior side of the heart, in between the interventricular groove, and basically supplies the posterior wall of the right ventricle and the posterior wall of the left ventricle. So thankfully, if that patient was left dominant, then you wouldn't have the backup system, the extra oxygenated blood flow that would be going to the posterior side of the heart. As you can see here, if you have an anomalous coronary, that's your left, you're already compromising the anterior side of the heart. You're already compromising the left lateral side of the heart. So if you add a posterior descending on top of that, you'd be basically compromising 2/3 of the heart with desaturated blood. So thankfully, this patient would be right dominant, and 85% of us are right dominant. So that's one factor. What do you think happens over time to a heart that's getting desaturated blood here?
Does it become weaker?
Well, it will become weaker, but what do you think the body does over time?
It looks like it develops collateral flow.
Yeah, so you get what's called angiogenesis over time. So your body's going to start forming these natural bypasses that are going to allow collateral flow to get to the ischemic areas. And in that sense, patients who have had chronic coronary artery disease, like let's say for decades they've had coronary artery disease. These are patients that have most likely developed a lot of collateral coronary circulation that has really helped their heart. I mean, my father-in-law had a bypass done in like the early 90s, and he's had some stents since, but I think majority of his bypasses are still open, and his heart has modeled itself over decades to actually have collateral circulation, which is a protective effect. The people that typically drop dead of a coronary artery disease are the ones that acutely get a blockage. And it's usually the athletic person who has a big, strong heart, a heart that chews up a lot of oxygen. And if you get an acute blockage in your left main or LAD, and they don't have this collateral circulation that has happened over time, that's when they get like the severe MI. And those are typically the ones that will drop dead of a heart attack. Someone like my father-in-law, if he were to get another blockage, his heart is probably modeled enough where there's enough coronary circulation going on where he can probably survive and at least make it to a cath procedure or a surgical procedure. So over time, the body is going to realize that this has been an ischemic area, and I bet you there's a big network of collateral circulation that's going on here to help supply the ischemic portions of the heart. So I know the fall wasn't that long ago, and you guys are experts. So let's call out the coronary anatomy here. What's this?
Left main.
Coronary artery.
Left main. Well, all right. Be a little more specific. We know it's coronary artery. Left main. All right. What's this?
Left anterior descending.
Okay. What's this? Someone else not named Owen.
Are you putting at the circumflex or the OM?
Okay. Circumflex going around OM here. Okay. And remember, you can have branches off of your OM, OM1, OM2, OM3. What would a branch off of your LAD be?
Diagonal.
Diagonal. And a ramus would be, not everybody has a ramus, but that's another branch that comes off the LAD. So that would be the ramus. All right, good job. So this is what?
Right main.
Right main. Okay. And what usually comes off, it's not here, but it comes off the right main.
Coronary. Sorry, I just did that thing. the nodal coronary.
Okay, nodal branch. Okay. So your right main runs underneath the right atrial appendage here. And then what comes here?
The PDA.
Well, this is front side of the heart still, or right lateral side.
Acute marginal.
Acute marginal. And then when it goes behind the heart, running down the posterior interventricular groove is the posterior descending artery. Remember, right dominant, 85% of patients are right dominant, 15% of patients are left dominant. We did a case not that long ago where the right coronary artery was compromised on a kid due to anatomical reasons and the surgery. And luckily, that patient was left dominant, which helped in the sense that being left dominant, she was still able to get good blood flow to the backside of her heart, even though her RCA was compromised. So there are different pathways an anomalous coronary artery can take. For Al Kappa, you can see here, you have the left main coming off the anterior portion of the pulmonary artery. Here you can see, here the left main's coming off more of a medial portion, okay? And then here you can see it's coming off more of a posterior portion. So there's gonna be some differences in the way the Al Kappa can present. And obviously, the more posterior that anomalous coronary arises, it can provide some higher risk for kinking. And you can see the surgical correction for this is known as coronary artery reimplantation. So they basically cut out a button here. You can see here's the button. And they move the coronary to the correct position into the left coronary cusp in the left portion of the sinus of Valsalva. Now, it depends. Optimally, you have enough real estate to actually successfully move that coronary artery over without kinking it. If it kinks, you're going to have problems because obviously now you're compromising coronary flow. But this slide is basically showing you the surgical correction, and this is known as coronary artery reimplantation. So that's Al Kappa. So we're going to go over ALMCA now, and there's kind of 4 subtypes of ALMCA. And ALMCA is anomalous left main coronary artery arising from the right sinus of Valsalva. So in ALMCA, your left is still coming off the aorta, but you have basically, instead of it coming off the left coronary cusp sinus, it's coming off the right coronary cusp sinus. So you have 2 coronary arteries, your right main and your left main, both arising from the right side of the aorta. And they've classified them into 4 subtypes, type A, B, C, and D. Type A, the left main courses anteriorly to the right ventricular outflow tract in order to reach the anterior sulcus of the heart. Type B, the left main courses between the ascending aorta and the pulmonary trunk. Type C courses with the crista supraventricularis muscle behind the RVOT to reach the anterior sulcus. And course D, it courses dorsally to the aorta before reaching the usual area of the bifurcation of the LAD and the circumflex. You're not going to have to know that type A, B, C's, and D's, but just shows you that there's a difference there. And this kind of gives you like a superior view of what ALMCA kind of looks like. So here you got your aortic valve. Here's your pulmonic valve. Okay. This is the non-coronary cusp. This is the right coronary cusp. This is the left coronary cusp. And you can see in ALMCA, you got the left main here. This would be a type A because it's going in front of the RVOT, arising from the same coronary cusp as the RCA and basically taking an anterior course around the RVOT. So obviously the left coronary artery should be coming off the left coronary cusp. What do you think the problem is here happening? We see the anatomic problem. What do you think the physiologic problem is?
Would it flow be going to 2 of the arteries instead of the 1, like in a normal heart?
Well, what stage of the cardiac cycle are the coronaries filling?
Systole?
All right, who agrees that the coronaries fill during systole? Emil's shaking his head.
I started diastole then, sorry.
All right. We agree, the coronaries fill during diastole. So what really, I guess, allows them to fill correctly during diastole? All right. Let's see how I draw here.
You're asking what allows them to fill properly during diastole?
Yes.
A competent aortic valve and decent pressure in the aortic root to get that blood into the coronaries.
Oh, I don't know what the heck happened there. I'm not using a mouse, so I'm going to do my best here. Okay. Sorry for the bad drawing. Let me go back to laser pointer. Okay, what area of the root is this? Think back to the fall.
Annulus?
Okay, no. Maybe it's my crappy drawing. Hold on.
Is it the sinus of Valsalva?
Sinus of Valsalva. Okay. What's the significance of the sinus of Valsalva?
Its bulb shape during diastole creates a turbulence that shoots the blood down into the coronary vessels.
All right, great answer. Great answer for a bad drawing. Can't really draw with my fingers.
Next year's got to get you a touchscreen.
So might you think, so basically the sinus of Valsalva during diastolic flow is creating this bruit going on here, okay? So you have, it's really enhancing coronary filling by creating this turbulent bruit that kind of does this. So with that being said, with ALMCA, you're basically not getting the full effect of the sinus of Valsalva. You're impeding that bruit happening because anatomically you have two coronaries coming off the same cusp. So coronary filling is compromised, even though it's still coming off the aorta, so which is better than L kappa that we just talked about. Coronary filling will be compromised. So that's ultimately what's happening in terms of a physiologic response from the left main coming off the right sinus. And then here's other iterations here. So just to show you like different examples here. Here, it's possible to have the right coronary artery come off the PA, okay? That's a possibility. It's possible to have the left main off the PA, you know, like we did in L kappa. It's possible to have the LAD, maybe the circumflex comes off the left coronary cusp, but the LAD comes off the PA. That's an iteration. All coronary arteries arising from the PA. That permutation can happen as well. So just know that there's many ways that the coronary arteries can be congenitally compromised. So this kind of shows you different configurations of ALMCA. You can have an anomalous left coronary artery coming off the same cusp, same right coronary cusp. You can have an anomalous RCA coming off the left coronary cusp. It can happen in different ways. So ultimately, if the coronary artery arises from the incorrect Valsalva, the incorrect cusp, the surgeons are going to do typically what's known as an unroofing. So this wouldn't be a coronary reimplantation. This is basically what they would do is what's called a coronary unroofing. And the slide I was working at on my computer had a slide that talked about the different techniques, but the slide off of your canvas doesn't. So I'll try to explain what a coronary unroofing is. So basically, reimplantation is kind of easy to think about. A reimplantation, they're taking the button off the PA and they're connecting it to the aorta. An unroofing is a little different. So in an unroofing, basically there's a shared, this slide doesn't really show it so well. But there's like this shared intramural surface here, typically. So what they do is they redirect basically the flow that would go into the coronary here gets redirected here. And since it shares an intramural surface, it's called an unroofing. So the coronary is not going to fill don't know why it does that. They will redirect the flow where the coronary will not fill at this origin, but it'll fill here. So the filling will come off the correct coronary cusp, and that's known as a coronary unroofing. I'll send out my slide. I added a slide that talked about the surgical correction. So L-Kappa will always have a coronary reimplantation. ALMCA has coronary unroofing, okay? And basically an unroofing involves a shared intramural course, basically, and it's a surgical way of redirecting the anomalous coronary to be fed from the correct coronary cusp. I'll add that slide. I'll send it on an email. I just added one slide. So L-Kappa, coronary reimplantation, ALMCA, coronary unroofing. And say those two don't work. What's the third way to correct this?
Would it be a root
Right.
replacement?
Anybody want to take a stab?
A cabbage.
A
Yeah,
cabbage.
bypass.
A cabbage. Can you do a cabbage in a baby? Nope. Kid has to get old enough to actually be able to, do a REMA or a LEMA. Odds are it wouldn't be a saphenous vein graft. Maybe if they're older, a saphenous vein graft. But yeah, just know that cabbage would be the third option and not really an option until the kids get much bigger. So 3 ways to attack this: reimplantation for L-Kappa, coronary unroofing for ALMCA, and a cabbage if on both of those, if the correction is not working. And obviously you can do the best job on a correction, but if the coronary is kinked in some fashion, it's compromised.
Hey Dave, I have a question.
Yes.
The second semester, I was able to see a case where somebody had a coronary anomaly with a left coronary anomaly coming off the right main coronary artery. So
Well, that's ALMCA.
Okay, so the anomaly wasn't coming off like the aortic root, but it was coming off the actual main right coronary artery.
Okay, so like this, where there's a single ostium.
Mm-hmm.
Okay, yeah, you can see there's different permutations. So what you saw was this.
All right, and so in that case, I guess what they decided to do, they had to replace the aortic valve, and they did the TAVR, and they left the anomaly alone, and then they deployed the valve, and they were just hoping that it wouldn't pop the artery. So I don't know if that.
After they deployed the valve in the TAVR, was there any like ischemic changes to the heart, or was everything okay?
But that's what they were looking for, was
Okay.
to see blood pressure would drop and things like that.
In TAVRs in general, when they redeploy that valve, that can compromise coronary flow just naturally, so that's something that they definitely look for, depending on where that deployment happens. It can compromise coronary flow. And I think with a single ostium, like you were talking about, Morgan, there's probably even a greater risk. And you can see with the single ostium, like you don't have a lot of wiggle room in terms of compromising coronary flow here. So as long as the patient was asymptomatic and still getting decent coronary circulation, they're not going to mess with that. Sometimes you just try to do the best you can. But this is kind of number C. Let's see. Yeah, C is kind of a good example here of what the unroofing would look like. So instead of the origin being here at R, they would make the origin here at L. because there's this shared space here that's going around the cusp. It's almost like they just redirect the flow to come off the correct cusp. And this is kind of just the incidence of coronary anomalies in terms of percentages. And you can see they vary, but it's still rare, which is good in terms of everything that we have to deal with. I mean, I've done a handful of these. It's not like we see them that often. So that was our little catch up from the last part of Tuesday's lecture. So I want to get into our next lecture, which is we're just going to go over basically pediatric perfusion techniques, which a lot of it's going to be a review. And then we'll talk a little bit about acyanotic considerations. All right, let's see.
That last slide with the percentages, I'm sure we don't need to know that, but on a lot of your presentations about these different anomalies we're looking at, there's an instance percentage. Is that something you'd like us to commit?
Yeah, no, I just throw that up there. In 1 second here.
Put it in the drawer if you have to move.
Okay. All right, you too. Okay, we can all see that. All right, so some of this is going to be a review, and then some of this towards the end, we're going to talk about just considerations you'd have for different types of procedures that would involve acyanotic defects. So we'll start off by discussing various pediatric perfusion considerations. That should be a review. We'll describe the oxygenator and circuit configurations that we've gone over before. We'll describe varying hemodynamic considerations based on the age of the patient. We'll go over cannula considerations based on calculated flow targets. That's something I'm going to want you to know for the exam. And then we'll describe various conduct of perfusion configurations based on various acyanotic and obstructive defects. So in terms of pediatric perfusion considerations as a review, we talked about how circuit size is an issue. Why, Emily, why is circuit size an issue?
You don't want to hemodilate your patients too much or use bigger circuit than you need.
Okay, so it's always going to be a balance in terms of meeting the patient's metabolic needs and not over hemodiluting them. And we're talking about a patient population that can be from 2.5 kilos to 120 kilos. Okay, so circuit size, you have large variance in the pediatric population. Because there's such a large variance, and we deal with neonates and small babies, that their blood volume compared to our prime volume is a high ratio. Blood product usage is pretty common in the pediatric realm because of the hemodilution. There's anatomical considerations because of all the congenital defects that we encounter. We're going to see a lot more anatomical variations in part 3 of this course. Why might we target higher cardiac indices in PEDS patients?
They need more,
Aorta. Go
sorry,
ahead, Sarah. No, you go ahead.
they need more perfusion because they're utilizing more oxygen as they grow.
Okay, I would say the younger the patient, the more metabolic they are. Okay. Residual shunts, if they have persistent fetal circulation, that could steal flow away systemically. So we have to flow higher to kind of counter that steal. D.O2. D.O2I, what is that?
Our oxygen delivery index.
Okay. So as perfusionists, basically D.O2 is what you're doing, okay? And I mentioned this kind of in the last section, but under normal physiology, what is our normal oxygen delivery ratio to oxygen consumption?
4:1.
Yeah, I would say normally about a 5:1, okay? What ratio do we stop aerobic metabolism and anaerobic metabolism kicks in and lactate?
That 2-to-1.
Okay, yeah, so 2:1. So ultimately, we're trying to be above that 2:1 level. Yes, our patients are not exercising, they're anesthetized, they're cooled, they're paralyzed. A lot of their metabolism has been lowered, but ultimately, we're trying to be higher than that 2:1 ratio. In kids, an oxygen delivery index greater than 300 mils per meter squared is usually what we're trying to target. There's been studies to show that this is really the optimal D.O2I that we are looking for. And how do we calculate oxygen delivery index? What do we have to calculate first? Should have got this in a perfusion class.
Volume,
Volume. All right, let's do flow. So if you're on pump, how are you going to calculate this?
Desired cardiac index times the patient's BSA.
Well, at any given moment, though, how do you know what your oxygen delivery is? Not what it's projected is. What is it currently?
The difference between your arterial oxygen and your venous oxygen times your flow.
Okay, we got to get O2 content first. So O2 content is what's going to be within the parentheses here. So hemoglobin times 1.34, which is a constant, times the saturation in a percentage, plus sorry, this is an away game for me. It's Julie's office. Plus PO2 times basically the calculation for dissolved oxygen, which is 0.003. Hopefully you can read that. So we got to get oxygen content first. So let me show you. We take the hemoglobin, times it by the constant 1.34, times it by the saturation percentage. Add that to the PO2 times the dissolved oxygen constant, which is 0.003. We take that number and we times it by the flow divided by 100. Okay, that gives us oxygen delivery. And then ultimately, we divide that by the BSA, and that gives us oxygen delivery index. So for peds, we really want to target that greater than 300 mils per minute. So what are factors that increase this number? What can we do to increase this number?
Go up on FiO2, go up on flow, and go up on, well, not go up on, but give blood to increase hemoglobin.
All right. What do you think will have the greatest result? So if I just crank up my FiO2, let's say my PO2 is 150, I crank it up to 300, and I leave all the other things constant. Do you think that'll change this much?
It's the hemoglobin.
Be the blood.
The two factors that are going to be the big determinants will be your hemoglobin and your flow the most. Now, we don't always want to just give blood all the time. You know, we actually want to be discriminate in terms of how often we transfuse our patients. So as perfusionists, I think we want to optimize our flow as best we can. And you may find with peds cases, as long as we have good drainage, even though we're cold, we may stay at a 2.5 index. As long as the surgeon is not complaining that we're flooding their field too much, you know, there's no reason why we can't still flow high. So flow is something we can manipulate, but we can't manipulate it fully because it's contingent on our venous return. It's contingent on how much our drainage is and how well we're draining the patient. So ultimately, if we optimize flow and we're still having D.O2 index issues, that's when we got to give blood. That's why we got to increase the hemoglobin. But always keep in mind, you know, flow is relative. You can say I'm at a 2.5 index, but that is relative. What's your hemoglobin? What's your D.O2I? You want to know more of the picture. We talked about how MAP, your MAPS, is very relative as well. We talked about how SVR really matters, gives you more of the full picture. An MAP of 50 when you're at a 2.5 index is different than an MAP of 50 when you're at a 1.0 index. They both say 50 on the monitor. Obviously, SVR is different for both of those. So I really want you to think as perfusionists in terms of oxygen delivery index. And with peds, there have been papers that have shown desired of 300 and above, at least 280 and above is kind of where you should be targeting. And that might force you to transfuse more than you want to. But again, in healthcare, it's we're scientists, but we're also artists, and sometimes blending the art and the science of things is really difficult. That's why we have a lot of information at our disposal to really try to make those decisions. We can't just roll say, okay, I need to be above 300. Let me just transfuse blood. Take everything else into account. Look at your blood gases, look at your lactates, look at your nears. If the rest of the picture looks pretty good, maybe this kid is tolerating a cardiac, a D.02 of 260 and metabolically looks okay. You know, not everything is always black and white when it comes to medicine. You try to use all the information at your disposal to really make good clinical decisions. Gas settings. We talked about oxygenators being very highly efficient. So a lot of times in our smaller kids and our neonates, we got to add CO2 because a little bit of sweep gas can blow off too much CO2. We talked about FiO2. Why does FiO2 matter with cyanotic patients?
You want to keep them sub-ambient or at an FiO2 of 21%.
I would say definitely if we want to keep the ductus open, but once we're on bypass, typically we don't need the ductus open anymore. But let's talk about at the tissue level. Let's talk about tissue that's been chronically hypoxic. Is it good to automatically introduce high PO2 blood to that tissue?
No, and it'll create an excess of oxygen-free radicals.
Right. So oxygen is a good thing, but too much of something is not a good thing. You really got to be cognizant on these patients that are chronically used to hypoxemia. All of a sudden, you add high oxygen to a tissue bed that has been hypoxic for a long time, and oxygen can be doing damage. So often, let's say we have a cardiac arrest in the unit and we got to crash a kid on ECMO. I'm not turning my FiO2 up to 100% as soon as we go on. That would be pretty catastrophic. Now, I guess your instinct is to say this kid has been without oxygen because they're doing CPR, and your instinct is to say get oxygen on, but physiologically that's often the wrong move. We often don't turn on our sweeps right away on an eCPR on a kid for maybe about a minute. And then when we do turn on our sweeps, we keep our FiO2s at 21%. Because we're really trying to avoid the oxygen free radical generation and the reperfusion injury that's going to happen. Venous return, small volumes in a reservoir, especially on our little kids, 10 mils, it goes a long way. Why do we target lower MAPs for kids, especially neonates? What do we talk about?
They have a very high level of vascular compliance because since they're so young, they haven't had time to calcify.
Right, so lower means gets transmitted peripherally very easily. They get really good perfusion with lower means. Whereas on an adult that has had peripheral vascular disease, less compliant vessels, stiffer vessels, you need that higher pressure to transmit flow distally. In a neonate, especially, why do we not want pressures to go too high? What can we damage?
The brain.
The brain is very susceptible in neonates. A very bad combination to add high pressure and anticoagulation. That's a cerebral bleed waiting to happen. So if I'm pumping a neonate and my pressures are above 45, I'm worried about that, and I'm doing things to counteract that pressure. And why is calcium important in kids?
I think isn't it they don't produce as much as adults do.
Okay, what's different about their hearts and their physiology?
Their sarcoplasmic reticular calcium uptake isn't so effective. And I believe you had mentioned they rely more on extracellular calcium to promote contractility.
Yes. So their SRs are immature. They don't generate intracellular calcium uptake, so they rely on extracellular calcium to generate inotropic contractility. And if their calciums are low, their hearts are not going to be optimized. They're not going to be squeezing as hard as they should be squeezing. And why are calciums kind of all over the place in kids when we do surgery?
Aside from that reason, we typically will have to give blood products or blood prime, and the citrate binds to the calcium.
Right. So giving 1 unit of blood on a patient that's 80 kilos versus giving 1 unit of blood on a patient that's 4 kilos. The ratio of citrate is a lot different. So blood products really affect the calcium in kids. And hypocalcemia is actually something that we're okay with when we're cross-clamped. It's actually kind of optimal. But once we take the cross clamp off and the heart is coming back and beating, it's more advantageous for us to get that calcium up to a high normal level, because that'll allow us to successfully wean from the heart-lung machine. And being at a higher level models the kid a little bit easier when there's platelets or cryo given post-operatively. There's not as much of a drop at that point in terms of calcium. And typically, when anesthesia gives the protamine, they usually give calcium with the protamine, so the calcium kind of stays normal. But calcium is very important in pediatric physiology. We talked about the variance in patient population, different circuits that we're going to pull. Basically, I pull my circuits based on size, and ultimately, size is going to dictate what my flow targets are. And here's the corresponding flow targets for my patients. And basically, my flow targets will dictate which AV loop I pull, which oxygenator I pull, which arterial line filter I pull, if you use an arterial line filter, which type of cardioplegia heat exchanger, and which type of hemoconcentrator. Talked about hemodynamic management. As the kid gets older, that's when our pressure targets typically are going to change. Less than 3 months of age, we're looking at 30 plus or minus 5. And this can vary between departments, but this is probably pretty standard. You can see as the kid gets older, basically above 5 years of age, we're getting more into what would be MAP targets that you would see on adults. Where I currently work, well, actually today was my last day. These are our hematocrit targets. So newborns, and we're looking at hematocrit targets 26 to 30%. And by the time we come off bypass and muff, we're looking at 32 to 36%. As the kid gets older, we can sustain lower hematocrits a little easier. So this is our protocols here. And basically that's going to be institution specific. Different institutions are going to have different transfusion triggers and ultimately what they're comfortable with. We're pretty aggressive in terms of trying not to give blood products. So we tolerate lower hematocrits than probably most institutions are comfortable with. But, we have enough experience with it where, we don't freak out if a kid has a greater than a year, 20% on bypass, as long as basically at the end of bypass and muff, we can get that above 24%, we're comfortable with that. But you may go to a different institution that has completely different protocols. The key is, can you justify your protocols? When you guys go out on rotations, you're going to see a lot of different ways of doing things. And that might throw you off. Sometimes the changes are big and it'll throw you off, but sometimes even minor changes will throw you off from what you're used to seeing. Ultimately, if something confuses you, ask your preceptors their rationale and do it in a way where you're not, it's not like, well, over at this institution, they do it this way. Why do you do it this way? Don't ask it like that. Just ask for their clinical rationale and things. And hopefully they give you a good answer in terms of why they do something. Just like we have to pick our circuits based on our flow calculations. The surgeons are often going to ask us, what cannula can I throw in? How do we pick cannulas? Why is there a flow designation for a cannula on the arterial side?
Pressure drop.
Okay, we want to avoid a pressure drop. If there's too much of a pressure drop across the cannula, what's the problem that's happening?
Hemolysis.
Okay, yeah, we increase our shear stresses. We increase our jetting. So not only are we potentially getting more hemolysis and blood damage, we could be jetting against the aorta, which could be causing intimal damage. So on your test, I may give you a flow target, and I may ask, which cannula would you pull? So on this slide, don't worry about venous flows, but on this slide, I would suggest your arterial cannula flows. Okay, that's a little bit of a hint. So if I ask you a test and say patient is such and such size, what arterial cannula you would use, by knowing this slide, you would know what to pick. Is that fair? And that we would pick our venous cannulas as well. There's a pressure drop across a venous cannula. It's a negative pressure drop, but ultimately size dictates what we can throw in. And I would say most surgeons want to throw in the largest cannula they can and that they can get away with, but ultimately anatomy is going to dictate what they're going to use. Sometimes they can't throw, due to the anatomy, they're forced to throw in a smaller cannula that can compromise things. But optimally, if they can throw one in and it doesn't compromise anything anatomically, they're going to use it. And, they try to throw in the biggest cannula that they can get in. I apologize. My allergies have been horrible with all this cottonwood going around. And I didn't take Zyrtec today, so I'm going to have to take a lot of drinks of water here. I would say these are the most common cardioplegic solutions you're going to see, be it adult or peds. St. Thomas solution, also known as Plegiosol, is a very commonly used cardioplegia. It was interestingly used as a crystalloid only cardioplegia. So all its constituents are based on being just a crystalloid cardioplegia. But I would say 99% of centers kind of use it off label. They use it in a 4-to-1 ratio. So they use it 4 parts blood, 1 part Plegiosol. That I guess over the years was a very common cardioplegic solution, but things are changing. Right now, the most common cardioplegia for peds is Del-Nido. And Del-Nido has definitely made its way into the adult world as well. It's a 1-to-4 cardioplegia. I'm sure you guys have talked about Del-Nido at this point, but I would say for peds, it's almost the gold standard at this point. And for adults, it's gaining a lot of ground, especially in valve surgery. Buckberg is a cardioplegia that was historically used. Usually there's 3 bags with Buckberg. You have your A bag, which is your induction, your B bag, which is your maintenance, and your C bag, which is your reperfusion. Buckberg is at a 4-to-1 ratio. Buckberg is a great cardioplegia solution. The problem is the A and B bags have D5 and the C bag has D50. So what do you think are the problems giving that in terms of what's happening systemically? It's great for the heart, but if its carrier is D5, D5, and D50, what do you think I'm fighting with all case if I give Buckberg?
A hypotonic solution, right?
Appropriate glucose management.
Yeah, the glucose is skyrocket. So the high sugar as a substrate is really good for the ischemic heart, but systemically, all that comes back systemically when you give cardioplegia. And you really deal with high sugars that you know, so giving insulin a lot during a case where you're giving Buckberg is pretty common. Microplegia, what's microplegia? You may have seen it in your lab.
It's all blood with the arresting agents in the blood.
Right. So I don't know if, do you guys have a Quest pump in the lab? I think at some point they will show that to you. But some of the sites you're going to go to have the Quest pump, which is essentially microplegia. Like Sarah said, it's just blood, and ultimately the components are added to the mix. There's no crystalloid component. Now, tell me an advantage of microplegia, and also tell me a disadvantage of microplegia, because it's on its face, it sounds great. 1-to-0 ratio, it's all blood. You're not getting all this hemodilution like you might on Delnito. We haven't talked about custodial yet, because custodial is a straight crystalloid. So what's an advantage of microplegia, and what do you think is a disadvantage of microplegia?
I was gonna say the reduced hemodilution, but I mean, you did just mention it. Is there another like really, you know, positive advantage of it? Or is that kind of one of the main things? Like if you have some huge 8-hour case, you're not overly diluting your patient.
I would say the main advantage of it is, yeah, you're decreasing the hemodilution because you're not giving a crystalloid component per se with your cardioplegia. So I would say that's the big advantage. What I actually think there's a big disadvantage to it. What do you think that might be?
Well, will it be that given the fact that we're not actually diluting the blood, we could have a high viscosity, and that can actually lead to less perfusion?
Great answer. So typically, are we giving cardioplegia cold? Would you say that's typically how we give it? And we're giving it very cold? Does cooling it down make it more viscous or less viscous? More viscous, okay? So if you're taking a cardioplegic solution that is very high in hematocrit and you're cooling it way down and you're trying to force it through the small vasculature of your capillary system in your myocardium, you may not be getting very good cardioplegic distribution. You could be getting a lot of capillary sludging going on. So I actually think the solutions that have more hemodilution have better microcirculatory flow in the myocardium. And I think that's why Delnito has been a very effective cardioplegia, because you think you're doing good things by giving a very high hematocrit, low dilution type of solution, cardioplegia, but you're potentially just sludging things up. So, and especially on, you know, areas that are tough to perfuse, maybe there's some compromised coronary anatomy. I really feel that the solutions that have more crystalloid in them have better flow characteristics in the capillary level. So that's my feeling. You're going to have people that, you know, swear by microplegia, and I'm sure you'll go out on rotations where you see the Quest system. And I'm not saying it doesn't have its place, especially long pump runs where you're given a lot of cardioplegia, you're talking about a lot of hemodilution. But I would think twice about using microplegia on a kid. And I think there's a reason why Delnito has been the gold standard. There's another type of cardioplegia that is a straight crystalloid. There's no blood component at all, and it's known as custodial HTK. Have you guys studied that at all? So
We very briefly have talked about it in the past, but I think it's the one that we maybe have talked about the least, actually.
Okay. Custodial HTK is used for organ transplants too. They use it as a preservative for organ transplants. It's an excellent cardioplegia. It's widely used in Europe. The only problem with it, and I have a big problem with it, I can't tell you how it's used in peds, but in adults, it's like a big 2-liter loading dose. And the constituents of custodial HTK plummet your sodiums. Like first of all, you give a 2-liter dose to start off the case. So you've just diluted your patient by 2 liters. Right off the bat, you've diluted your patient by 2 liters. So clearly you got to start hemoconcentrating to get the volume off. But it plummets the sodiums. And I think, to me, that's a little dangerous, especially for neurologic outcomes. Apparently, there's plenty of studies that show that it's okay, but I get nervous when sodiums go that low. So I'm not a big fan of custodial HTK. I've never used it, but everything I know about it would kind of scare me to use it. Here's kind of back when I was at Rush, when we give Buckberg for peds, this was our protocols. And things I show you like this, just so you know, it's very institution specific. So I don't want you to think that this is the only way to give Buckberg, but how we would do it, we would do an induction. We'd use that A bag. We do 750 times the BSA, and that would tell us our A bag induction dose. And our maintenance doses would be 500 times the BSA. So that's how we would deliver Buckberg cardioplegia. Now, Del Nido, this one I do want you to know, because this is pretty standard with Del Nido delivery. An induction dose of Del Nido is 20 mils per kilogram. That's a pretty standard induction dose. And when you guys have studied, how much can our induction dose typically last us?
Can it be around 75 minutes?
Yeah, I would say that would be a higher end of where you're targeting. Where I work, around the 50-minute period is when we redose, if need be, especially if we're not going to be taking the cross clamp off anytime soon. But you can safely go above an hour, which is pretty impressive. But I think most places don't push it that much. But it just shows you that one dose, you can get a lot done surgically without having to give subsequent doses. If we do give a maintenance dose, it's typically 10 mils per kilo. That's typically our maintenance. Now, let's say, put your surgeon caps on. Let's say we're doing an ostium secundum ASD. We're going on pump for an ostium secundum ASD, which is probably our shortest pump run that we're going to have. Would you advise to give a induction dose of 20 mils per kilogram? No. So on the cases where we're really anticipating a short pump run, that's when we'll modify our induction dose. Maybe let's do 10 mils per kilogram. Because ultimately what happens when you give this Del Nido dose, you don't want to be taking the cross clamp off shortly after you give Del Nido, because the heart's going to be real sluggish to come back. It'll come back, but it'll come back very sluggish. So you kind of want to, if you know it's going to be a relatively short cross clamp time, you don't need to give the full induction dose. You give half the dose, and that'll allow the heart to kind of bounce back much quicker, which is ultimately the goal with cardioplegia. You want to arrest it when you need it, but when you're done using it, you want it to bounce back. And Del Nido solution uses high amounts of magnesium, high amounts of potassium, high amounts of lidocaine, and ultimately that's how it's getting its arrest. So if you guys had to give a goal, like how does cardioplegia arrest the heart? By what mechanism is it arresting the heart? All those different plegias, while they're different in their makeup, they're trying to accomplish the same thing. So
they block the action potential.
Okay, and they're doing that by overloading the sodium potassium ATPase pump. Okay, so ultimately that creates a diastolic arrest, and by creating a diastolic arrest, just arresting the heart in general, stopping it from beating, dramatically reduces the metabolic demand in the workload of the heart. Giving it a cold temperature dramatically reduces the metabolic demand of the heart. So you get potassium is often the arresting agent. Then you get this hyperpolarization if there's potassium, if there's magnesium, and ultimately it creates like this sustained repolarization. So here's kind of what Del Nido is made up of. So the increased potassium and magnesium and lidocaine lead to a hyperpolarization and sustained depolarization. Magnesium and lidocaine contribute to decreased injury through reducing the intracellular calcium accumulation. So this is kind of where it's interesting, where under cross clamp, we want low calciums. Once we uncross clamp and the heart starts beating again, that's when we treat the calcium. But low calcium, hypocalcemic states have been shown to protect the myocardium. So while the heart's ischemic, we're totally okay that our calciums are low. We don't need to be treating calcium under cross clamp. And the mannitol that's in Del Nido is active in decreasing cell swelling, and it's a good oxygen-free radical scavenger. And we give this at the 1 to 4. So pharmacy makes it up for us, but in a jiff, if you had to make up Del Nido, this is the constituents you would use. And all these are readily available to us in pretty much any drug box that a perfusionist has access to. So if need be, you can make Del Nido on the fly, but we rely on our pharmacy to have it. But sometimes they run out, and if they run out, or middle of the night and you can't access pharmacy for some reason, you can make your own. Talked about the oxygenators. Here's our Terumo FX oxygenator. The FX series has the integral filter. So it's an oxygenator and it's a filter. Static prime volume of this is 43 mils. So it's 43 mils to fill this tiny oxygenator. It has a surface area of 0.5 meters squared. And its manufacturer related flow is 1.5 liters per minute. Although we can push it to 1800. And especially if I'm not expecting too long of a pump run, I don't mind pushing this to 1800. The next size up, as you can see, goes from 0.5 meters squared surface area to 1.5 meters squared surface area, which basically is an addition of 100 mils of a prime volume. So it's always kind of those in-between kids where you got to make that decision. Do I keep the smaller oxygenator and potentially not be able to oxygenate fully, or do I do the step up? I will say if you're really conflicted about it, it's always safer to do the step up. Even though you're compromising in terms of hemodiluting more, you never want to be in a situation where your oxygenator does not have the horsepower it needs to accomplish what you're trying to do. You never want to be up at 100% or FiO2, have your sweep maxed, and still be under oxygenating a patient. That's a scary scenario as a perfusionist. So, and that's when you're kicking yourself, where I should have picked the larger oxygenator. So if it's a quick, relatively quick case, sometimes you can push the envelope more and get away with it. If I know I'm going to be on pump a long time and we're cooling down more than typical, I will use the larger oxygenator. Ancillary devices. Hemoconcentrators are a standard of care in pediatrics. You're not going to see if you see a pediatric case that doesn't have a hemoconcentrator, they're doing something wrong. Adults, I think it should be a standard of care. Not all places routinely use them. Sometimes they use them just, sometimes. I think it should be a standard of care, but peds is absolutely a standard of care. Some type of inline blood gas monitoring is a standard of care. The CDI gives you nice real-time data that you can adjust your gas flows and your sweep flows. You can watch trends on your potassium and your pH. And again, NIRS is used in the adult side, but it's basically a standard of care on the ped side. And on our smaller kids, we will put one pad on the head, one pad on the flank. The flank will give us essentially regional renal perfusion. And everything that you think would make the NIRS increase, it responds to. Everything that you would think that would make NIRS decrease, it responds to. So if I have a NIRS, if I go on pump and I notice my cerebral oximetry start to trend down, what are things as a perfusionist I can do to get that to go in the other direction?
I could go down on my sweep and up on my flow.
Okay, what would going down on your sweep do?
Increase my PCO2, thus dilating my cerebral vasculature.
Okay, good. And then you would go up on your flow to do what?
Get more blood and oxygen up there.
Okay, to increases your O2 transfer, right? Now, let's say you've done both of those things, and I agree with you, Mike, those were the right moves, okay? And hopefully you're starting to cool as well. You know, usually the first half of the case is we're instituting hypothermia of some degree, usually moderate hypothermia, but that should help as well. But let's say you've done those things, we're cooling, and your NIRS still continues to go down. What's your next move?
Would you do pulsatility? Sorry.
Or go, Emil.
So will you first of all check to see if this nurse is well positioned? Then second, will we check to give perhaps hemoglobin?
Yes. So at that point, and I agree, if the pad looks off, it doesn't hurt to go under the drape and to see that the pad's still on. You know, if things kind of look a little wonky on the monitor, it's a good thing to check. And I have at times asked the anesthesiologist, can you check, does the pad look like it's still on? The Somanetics pads used to, with darker skinned babies, it wouldn't read correctly, where the Foresight we use is more sensitive to darker skin. And I think Somanetics has fixed that problem. So I remember back in the day, we'd always have issues with that. But when the baby comes in, especially if they're like newborns, their heads are greasy, okay? You stick a pad right on, and it's not uncommon for that pad to come off a little bit, you know, or to be compromised. So at Advocate, we put the pads on, Perfusion puts the pads on. So you know, kid comes in the room, I'm taking an alcohol swab, and I'm trying to get all that grease off their forehead. I wait X amount of seconds for the alcohol to dry, and then I make sure I get a good pad placement on the head. Places where anesthesia puts it on, you know, maybe they don't do it as put as much attention to it, but you know, I've dealt with it enough to know that the pad migrating can be an issue. But let's say we've checked that, Emil, and the pad's on correctly. Emil was correct in saying at that point, if flow, if sweep, if temperature, if pad placement has all been rolled out, that's where we're going to increase our hemoglobin. And we talked about on our D.O2, in terms of our O2 content, we're going to increase O2 content by increasing our oxygen carrying capacity by giving blood. Now, I do like the way you guys were thinking, where giving blood wasn't the first thing you came up with. Because as perfusionists, that should always be the last thing we want to do. It should be the necessary evil that we want to do. We tried to manipulate all the things we could manipulate. It wasn't working, so we had to give some blood at that point. So good. I'm glad you're thinking in that like that. We talked about this is relative. It's not a perfect system, but usually less than 10 kilos. The blood volume of the kids will be 85 mils per kilos. 11 to 20 kilos, they're usually 80 mils per kilo. And you can see how it progressively goes down as the kilograms go up in terms of blood volume by weight. Not perfect because we always don't know how much they diurese. We don't know how much volume anesthesia is given. So there's a lot of factors to control there, but this is about standard in terms of what's accepted. Might be on your boards. I haven't taken the boards in, 25 years, so who knows? Common additives for prime for pediatrics. Giving blood is typically the gold standard in the prime for like less than 8 kilos. Where I'm at Advocate, we do an asanguinous prime as mentioned. I'm going to be going to Lurie Children's where they're going to be priming with blood, probably a lot more than, probably give a lot more than what I'm used to. But they will put pack cells in their prime, they'll put FFP in their prime. And common constituents obviously is heparin, bicarb, mannitol, albumin. If we have time, in which we should, if it's not an emergency, after we blood prime, what do you think we should do as perfusionists?
Check the pH of your prime.
Yeah, get a blood gas from your prime. You don't want that prime to be, you want that prime to be normal. You want the pH of it to be normal, the CO2 of it to be normal, the PO2 of it to be normal. If that's a highly acidotic prime, that's going to do damage once you go on, okay? Keep in mind as perfusionists, everything we do is insult to the body, everything we do. We always want to minimize that insult. And there's no reason, if we're talking about blood volumes, it's quite possible my blood volume is the same, my prime volume is the same volume as the blood volume as the kid that I'm about to go on bypass with. You do not want to introduce a highly acidic prime to a kid with that amount of volume. It's just, all those things increase the deleterious effects of cardiopulmonary bypass, and that's what we don't want to do. So if you have time, you take a blood gas from that prime and you make adjustments to that prime based on what that blood gas looks like. I showed you this slide that shows common CPB related checkpoints. When you guys do SIMS, do you essentially follow an order that looks somewhat like this? Because whether you're doing peds or adults, there's going to be, the loading the airplane, the checklist of the airplane, the taxiing on the runway, the taking off, the cruising altitude, the descent, the landing, the unloading the airplane, okay? Regardless where you're flying, if you're flying from here to Detroit or from here to Europe, doesn't matter, right? You're still kind of going through a lot of the same steps have to be accomplished. So I want you to always kind of think of that order when you're doing your SIMS, when you're observing cases, and ultimately when you're pumping cases. And in terms of situational awareness, I want you to really establish, where have I been? Where am I at? Where am I going? Those are the 3 questions I always want you to be able to answer or attempt to answer when you're on bypass. And you'll find that those questions are tough to answer early on in your training. But those questions, as the weeks go on rotation, you will start to answer those questions better in your head. And when you can do that, you're starting to learn and you're starting to connect dots, and things are starting to make sense to you. The best thing as a perfusionist we can do is anticipate the next step. When you start to anticipate the next step, that's when you're really starting to learn surgical progression and basically your role within that surgical progression. So I'm not going to go by, each item here. It's pretty self-explanatory, but you can see how all these items are in a specific order for a specific reason. And whether it's peds or adults, you're going to be following those, essentially that same timeline in some iteration. Sometimes in a dire emergency, you can't completely do a checklist, okay? Sometimes that you're going to be faced with that. But 99% of the time when you have time to do a regular setup, you have to do your checklist. And you got to be pretty precise with it. And it's not a time of the case to skip through and just to check. Okay, let me go grab my coffee. You wouldn't want your pilot to do that. Your pilots go through a really rigorous checklist that makes sure everything is ready to go. You as perfusionists have to do that as well. Just because you set up the pump perfectly yesterday doesn't mean you did that today. And before each case, you got to make sure your pump is safe and ready to go. And some institutions have very intense checklists, some don't. But ultimately, just know when you get out there in the real world, in a court of law, it's on you. It doesn't matter what the other perfusionist did. You got to make sure your pump is ready to go and is safe to use for the bypass run. So that is not a time to hurry up on things. You want to make sure your circuit is safe. All right, so we're going to kind of just get into basic perfusion considerations for acyanotic defects. And because these are acyanotic defects, the perfusion considerations aren't that major, but I want you to think about it. So here's an ASD. What are the three types of ASDs?
Ostium secundum, ostium primum, and sinus venosus.
Okay, good. Someone besides Owen, where's the ostium secundum located?
Where the foraminal valley would be.
Okay, in the area of the foraminal valley. Brianna, is it a foraminal valley?
No.
Correct. And do these always need surgical intervention? 50% of the time, they'll close on their own. The other 50% of the time, 90% of that they can get actually closed in the cath lab, and the other 10% they'll need surgical intervention. And in the cath lab, they do that device closure, but the device closure doesn't always work. And as you can see, when I got called in a week ago, sometimes if there's not a good ridge, there's not a good landing site when they deploy it, and it can migrate. And on the kid last week, it migrated into the right ventricle. And that's where, so we put the kid on pump. The surgeon reached in through the tricuspid valve and, with forceps and pulled out a very large device. I think the largest device they actually make. That shows you how large of an ostium secundum defect that was. Maybe that kid shouldn't have went to the cath lab in the first place. That probably should have been a surgical patient right off the bat. Okay, so that's the secundum. Let's talk about the primum. Someone besides Owen who wants to tell me where the primum's located.
Lower part of the atrial septum.
Okay, and what's associated with the primum?
Mitral valve clefts and partial AV canal.
Okay, great answer. Third one, sinus venosus. Where's that located?
Upper part of the atrial septum.
Okay, near what area? Where the SVC meets the RA, right? What's associated with sinus venosus ASD?
Right superior pulmonary and right inferior pulmonary. Something with a V.
So partial anomalous pulmonary venous return. Now that can either encompass just the right superior, or it can encompass both the right superior and right inferior pulmonary veins. So good answer on the primum, where it's associated with a partial AV canal and mitral valve cleft. Sinus venosus ASD is associated with PAPVR. Okay, and the partial the primum and the sinus venosus will not close on their own, and they will need surgical intervention. But typically an ASD is going to be one of the more basic procedures that we do in pediatric congenital surgery. I would say the ostium secundum being the most basic one we do. The primum and the sinus venosus are a little bit more involved, especially this sinus venosus, because remember they have to create that intraatrial baffle that will baffle the partial anomalous pulmonary venous return to the left side. So there's a little bit more involved in terms of a surgical correction. By looking at this defect, what type of venous cannulation will we do? Will we do single or bicable?
By cable,
Okay, why bicable?
because you're entering the heart.
Right. So we're going to want to have an SVC venous cannula and an IVC venous cannula. We're going to want to snare, because clearly we have to open up this cardiac chamber and expose the inside of the heart to the atmospheric air. And if we are not bicavally cannulated, we're going to suck a lot of air down our venous line and most likely get an airlock. Are we going to want to rest?
Yes.
Yes, so we'll give cardioplegia, but this might be a case that we give the 10 mils per kilo of Del Nido, because we're expecting a pretty fast case. So for instance, last Friday when I got called in, I had to battle traffic to get there, and they forgot to call me, which is a different, story altogether. But we got on pump. That was a 25-minute pump run. First, once we got on pump, we gave cardioplegia. First thing the surgeon did was open up the right atrium with forceps, retrieve the device that was in the right ventricle, and then patch closure of the ASD, close up the right atrium, came off pump. It was a very quick case. So ASDs are going to be probably the quicker cases we do. So we give 10 mils per kilo of Del Nido because we're anticipating a short cross clamp time, and we're not going to cool very much on these patients either. So keep that in mind. It's not like we got to cool down to 28 degrees. Typically 32 to 34. I would say if it's a secundum, probably closer to 34. There's no, your rewarming is going to be potentially longer than the actual surgery. So there's no need to cool all the way down on these cases. Now, just so you know, short bypass runs are great, but a lot of times there are hardest cases because you don't have time to really catch your breath. You're constantly moving. You're barely able to draw blood gas and chart that, and then you're rewarming, and sometimes it's tough to really be on top of the next step because you feel like you're chasing your tail. So I love short bypass runs, but sometimes they're some of the more stressful cases as a perfusionist. So you need to move fast and be on top of things on short bypass runs. VSD. What are the 4 types of VSDs?
You'll have the conal, the paramembranous, the AV canal, and muscular.
Awesome. Which one is the most common?
Paramembranous.
Paramembranous. Good. And we talked about how the AV canal, while it's still classified as a VSD, it's really an endocardial cushion defect that has multiple issues going on. So what type of venous cannulation?
Bicable.
Bicable. We're obviously going to arrest. Can they use a pericardial patch to close the VSD?
No,
Why not?
because it's muscle.
It's muscle. It'll tear that pericardium. So what can they use to patch it?
Vortex.
Vortex.
Gore-Tex. And Gore-Tex is an amazing substance because the body doesn't see it as foreign surface. So VSDs, I would still classify as a fairly fast procedure. Should be a fairly easier procedure. I don't like to put the term easy on anything we do. It's some of our least complex surgeries. AV canal makes it more complex. So an AV canal, I would definitely say, doesn't necessarily fall into that category. What could be difficult about muscular defects, just so you know, there could be multiple ones. They can have multiple holes, Swiss cheese VSDs, and the more apical they are, the harder they are to locate and to close. So you hope those can potentially close over time on their own. So yeah, we'll bicavally cannulate. We'll give cardioplegia. Odds are we won't cool the 34. We'll probably cool the 32 at most places. LV vent. Where's the LV vent placed?
Left ventricle through your pulmonary artery.
Pulmonary artery or pulmonary vein?
I mean pulmonary vein. Through
Okay.
the pulmonary vein into the left ventricle.
All right. So usually they're right superior pulmonary vein vents, where that's where they enter. They're introduced into the left atrium, hopefully past the mitral valve, and hopefully they sit here. And what's the whole point of the LV vent?
Is it to upload the left ventricle?
Right, correct. So why we don't want the left ventricle to get distended during the case, especially when you have a heart that's already decompressed and arrested in diastole. You can do definitely damage to the myocytes by overstretching it. But we're on bypass. Why would the left ventricle get distend while we're on bypass?
I mean, there is buildup of pressure if we having a lot of fluid going in there, of volumes.
How can the left heart still get volume if we're on bypass?
There's a lot of different ways that blood returns to the heart, not all of which goes, into the either SVC, IVC, or coronary sinus. We talked about some ways that blood can get in to the left atrium, and then it could distend the left ventricle.
Okay, so even though the lungs are technically out of the circuit when we're on cardiopulmonary bypass, they're still being perfused by bronchial flow, right? So you have constant bronchial return that's going into your pulmonary veins, which can distend your left ventricle. You got the Perfusion flow. And ultimately, if you're snared here and you give cardioplegia, it's going to come out your coronary sinus. So that's where your drop suckers come into play, because you're going to have return that in the heart that is going to need to be taken care of. So just because you're on bypass, there's still going to be return to the heart. So it's really important that we LV vent. On most cases, not all cases need LV venting, but PDA we talked about. It's odd that we would ever use cardiopulmonary bypass to close a PDA that's by itself, that has no other defects associated with. So isolated PDAs, it's going to be rare we ever go on bypass for that. But we talked about how a PDA is very common in conjunction with other defects. And we talked about the ductus being very important for ductal dependent defects. And you will understand ductal dependent defects much more in our next section. We'll talk a lot about ductal dependent defects. But as a perfusionist, if there's a PDA, what are you taking into account? What's important if you know there's a PDA?
Kind of goes back to what you'd mentioned about shunts, residual shunts, and needing to have a higher cardiac index.
Yes. So if that residual shunt is a open ductus, you know there's going to be steal, okay? So there's going to be systemic steal from your flow, which is going to be going through that ductus into the lungs. So that's going to be taking blood away from your systemic flow. And ultimately, you're going to have to counteract that by coming up on your flow. And a patient with a patent ductus, as soon as you go on bypass, you may really see those NIRS plummet when you go on because systemic flow, you're stealing away from it. So you got to really counteract that with higher flows. Same thing with MAPCAs. And we'll talk more about MAPCAs in the next section. But those are major aorto pulmonary collateral arteries. So in patients with severe cyanotic defects, we talked about how angiogenesis happens in the heart when you have a mottled heart that has been hypoxic for a long time, chronically hypoxic. Your body creates different angiogenesis to pathways for collateral circulation. MAPCAs are collateral circulation to get more blood flow to your lungs. But when you go on bypass with a patient that has MAPCAs, again, your systemic flow can plummet because your flow is taking a path of least resistance through those shunts. So that's, as a perfusionist, you got to be cognizant of that, and you got to increase your pump flow as necessary. So your targets will typically be higher when your patient has a PDA due to the left to right shunting. NIRS may plummet and MAP may plummet, and that may be your first indication that systemic steal is happening. Isolated PDAs are not going to need cardiopulmonary bypass typically. AV canal, okay? So again, endocardial cushion defect. We talked about, what are the 3 types of AV canals?
Partial, intermediate, and complete.
Okay, what's a partial? What happens on a partial?
It is effectively a ostium primum defect.
Okay, and that primum defect has done what?
That may have some interference with the development of the mitral valve, but it's near the endocardial cushion at the bottom of the atrial septum. Then the intermediate is going to have a fused but separate AV valves, and will also have some sort of ventricular septal defect. And then complete is what we have on the screen, where there's one shared AV valve and complete communication between all 4 chambers.
All right, great answer, Mike. See, you guys are understanding Pete's congenital, so keep it up. So on an AV canal, we're going to do bicaval venous cannulation, obviously cardioplegic arrest. Typically a target temp at 32 degrees. With a total AV canal, what are we concerned with?
If it's a balance or unbalanced.
Okay, so what happens during a balanced AV canal?
So during a balanced AV canal, so even though it's just even though the right and the left ventricle function as one ventricle, but the saturated and unsaturated blood are evenly distributed. Whereas in unbalanced, one of the ventricle is actually doing more work than the other, if I'm not mistaken.
Okay, good answer. In a balanced AV canal, just know that both your LV and your RV, the end diastolic filling of it is essentially the same. And you should have 2 normally sized ventricles. You'll still be getting mixing of a left to right shunt happening, but these patients are much more stable. They have an acyanotic left to right shunt, and even though you have this big gap here with this endocardial cushion defect, their end diastolic volume and systolic volume are pretty much the same. Unbalanced is when this common AV valve is going to preferentially open towards one ventricle or the other, And in severe unbalanced AV canals, just know that that's where we're getting into single ventricular physiology, where even though there's two anatomic ventricles, one is essentially doing the work for both. So one is pumping both through the pulmonary and through the systemic. And that would definitely dictate the type of repair we do. Now, if it's a balanced AV canal, we can typically do that later, not right after birth, maybe 2, 3, 4 months, depending on how the kid is thriving. Unbalanced AV canal, especially a severe unbalanced AV canal, we're doing in the first week of life. We're treating that as a single ventricle, and we're doing a staged palliation on that kid. And you may not know what a staged palliation is yet, but you will. So ultimately, the more involved cases will be longer pump runs, and that may dictate ultimately how far we cool down. The partial AV canal should be the fastest pump run out of all of them. And remember too, what's difficult about a total AV canal, a complete AV canal, is doing the single patch technique, the double patch technique, or the modified single patch technique, where they have to reconstruct that AV valve into being a separate tricuspid and separate mitral valve. And it's never perfect. Think of pediatric congenital surgeons kind of like plastic surgeons of the heart. They're doing their best to make a valve as competent as possible.
Hey, Dave.
Yes.
I'm sorry. I was just wondering, I had a quick question about the previous slide before you start the next slide. Right there on the right, it says partial AV canal with prime MASD and then PAPVR in parentheses.
Yeah, that's a typo. I apologize for putting that in there.
Okay.
Thanks for noticing that. But yeah, X that out. Because we know that the PAPVR is with the sinus venosus ASD. Good catch. What's the problem with coarctation?
Narrowing of the aorta.
Okay, it's a narrowing of the aorta. What's it physiologically doing here?
Not allowing oxygenated blood to be systemically shunted down within the aorta. So it's off the blood flow of oxygenated blood.
Most coarcs will allow blood flow through. There's just going to be a pretty severe narrowing. If it's a real severe coarc, it's almost an interrupted aortic arch. But sometimes a severe coarc will need, we talked about a ductus being patent in order to get flow distal to it. But this is an obstructive defect that's causing an increased workload proximal to that defect, and a decreased perfusion and pressure distal to that defect. So oftentimes coarcs are done off pump, where they clamp and they do a quick patch augmentation of the aorta and then take the clamps off. But sometimes if they feel that's going to be an extended time of lower body circ arrest, they will go on the heart-lung machine. Now you could do bicable cannulation at any time. There's no rule saying you can't do it, but this is an instance where you could get away with a single right atrial cannula. You don't necessarily need to do bicable cannulation on a coarc. Why is that?
The RA is not getting open, so there is no need.
Right. So if you're not opening up the chambers of the heart, it's not necessary to do bicable cannulation. Just like when you see cabbages happen. Okay, cabbages are not technically an open heart procedure. They're working on the top side of the heart. They're not opening chambers. That's where you'll see the dual stage cannula used, single right atrial cannula. And if it's a dual stage, you're also going to have a chamber here, but you're not opening up the chambers of the heart technically. So when you do that, you can use a single venous cannula. You would do a bicable cannulation if there's septal defects. Aortic cross clamp is not technically going to be necessary. They will put a cross clamp here, but that doesn't mean we have to arrest the heart to do that. So let's say we're not going to arrest the heart. We're gonna go on bypass. What might we do to make sure we're still getting distal perfusion by going on bypass? What can we potentially do surgically?
2 arterial cannulations.
Yeah, you can do a dual arterial cannula if you feel it's a severe enough coarc and you're going on bypass to really minimize any time of lower body circ arrest. You can do a dual arterial cannulation.
Would you consider left heart bypass?
I would say on a kid, probably not. On adults, you could definitely get away with left heart bypass, but an adult with a coarc, maybe it's a kid that had balloon dilatation earlier on and ultimately needs a repair. But yeah, left heart bypass is definitely doable here. Does everybody understand what left heart bypass is? Either way, you're using the heart-lung machine to empty the heart enough, because as soon as they put a clamp on here, you're gonna ultimately want to control the amount of blood you have going proximal. So proximal pressures, once this clamp goes on, will skyrocket. So you're going to want to make sure you're lowering your flows, taking off enough volume, but still allowing enough volume in the heart to eject properly, proximally, and then ultimately you're going to be providing pump flow distal to that coarc. Interrupted aortic arch is more commonly when cardiopulmonary bypass is utilized. If there's going to be no circ arrest where you're using 2 cannulas, there's really no need to go real low on your temperature. If you're going to use 1 arterial cannula and there's going to be a period of lower body circ arrest, that's when you're probably going to want to cool more, okay? Because cooling will give you more of a safe period. It'll protect your spine more. It'll protect your kidneys more. If there's going to be circ arrest, just know that anytime that there's circulatory arrest, you have the potential for metabolic acidosis and reperfusion injury. So we talked about potential double arterial cannulation will ultimately avoid circ arrest altogether. Subvalvular aortic stenosis. This is when we have superfluous tissue that is below the aortic valve, causing a narrowing and causing a stenosis of the left ventricular outflow tract. Bicable cannulation, cardioplegic arrest. Because they're getting into the left ventricular chamber, you don't have an LV vent per se in terms of a right superior pulmonary vein vent. This is where you'll have a drop sucker. So a drop sucker directly into the left ventricular chamber. Ultimately, when you close up, you may put in a root vent. So you're going to want to vent out of the aortic root. So any air that's getting past the aortic valve should be captured by the root vent. Should be a typically quick case because they're just resecting that subvalvular extramuscular tissue. So you're going to cool anywhere from 32 to 34. Just know any case that has congenital aortic stenosis, whether it's valvular stenosis, subvalvular stenosis, supravalvular stenosis, you may have left ventricular hypertrophy. Okay, because you have that ventricle that's been pumping against a high afterload, and chronically pumping against a high afterload is you're going to get a hypertrophy ventricle. So when you have any heart that has been hypertrophied, potentially may need more cardioplegia for protection, because it's a bigger muscle. It's a muscle that potentially may not get perfused very well with your normal loading dose. So you may find that you have to give more cardioplegia on these cases. Ultimately, a lot of aortic surgery you can do with a single venous cannula, but sometimes on a subvalvular stenosis, you're potentially entering the right heart with the surgery. So it's probably more common practice to do bicable cannulation. Supravalvular stenosis. What type of venous cannula will we use here?
Seems like you could use a single stage, or I mean, just a single right atrial cannula.
Yeah, again, you can always use bicable, but you could get away with a single right atrial cannula here because you are not opening any cardiac chamber. You're going to go on, you're going to cross clamp, and you're going to open up the root here, and that's where you're going to patch and repair the ascending aorta or the aortic root, depending. Again, should be a relatively quicker case. Again, keep in mind you may have left ventricular hypertrophy, so more cardioplegia. And ultimately, you will want to put in a root vent because when you're working on the left side of the heart like that, the outflow tract, you're going to want to make sure you're well de-aired before you come off the heart-lung machine. Mitral valve stenosis, what type of venous cannulation?
Bicable.
This is bicable on the slide.
Yes, because this is an intracardiac procedure. So bicable cannulation, cardioplegic arrest, typically moderate hypothermia. You'll have another drop sucker in there because you're going to be already working on the left-sided chamber. So you'll probably have a drop sucker. L Kappa, what type of venous cannulation? You can get away with a single right atrial. They may throw in bicable, but you can get away with a single right atrial because ultimately it's going to be a button that they're going to take off here. And what's the surgical procedure they do for L Kappa?
Coronary reimplantation.
Coronary reimplantation. If this was ALMCA, what would they do?
Coronary unroofing.
Coronary unroofing. You guys are becoming pediatric experts. You may cool more on these cases, and ultimately, really, the real issue with these is, do you have enough real estate to take this anomalous left coronary and bring it over to the correct sinus of Valsalva on the aorta here without kinking it? That's really the key.
Why would they cool more?
It potentially may be a more complex case in terms of a pump run. And you would definitely want to give good cardioplegia, but just know that the cardioplegia you're typically giving is just perfusing this right coronary artery. So the more cooling will give you more of a cardioprotective effect. They may go on and give separate osteal perfusion down the anomalous coronary here, okay? But you're also talking about a pediatric case where osteal perfusion is really difficult. You're talking about really tiny ostia, and it's not always doable to selectively perfuse the coronaries like you do in bigger kids or adults. So the more cooling would give you added cardioprotective effect. All right, do you feel like you're ready for Tuesday's test?
No.
See, I disagree. I think you are.
After a weekend of studying, I'm sure we'll all feel better.
Yeah, from my standpoint, I feel like you're understanding the material from my standpoint, and you probably know more than you think you do. But go over the lectures. I'm not going to be trying to throw you curveballs. I just want you to understand the material. And that's really the key. I want you to understand the material and be able to apply it in terms of perfusion concepts. It's not just about knowing the anatomy and physiology. It's also about understanding our role as pediatric perfusionists. you've gotten a good kind of basis of congenital defects thus far. Just know that the next section is going to get much more complex, but you have a good foundation now in congenital defects, where I think being able to understand the next section will be much easier for you. Any questions on the lecture or the test? We do have a little time. I don't really want to discuss rotations too much, but they're a work in progress, and I so far like the last iteration I sent out in terms of how things are lining up. Let me know if there's any other concerns, but also know I don't have a lot of wiggle room on things, as you can see. But I really tried to even things out where people are getting enough of everything. And it's looking like peds are pretty decently distributed. It's possible towards the end of your rotations, and the last half of your third rotation, you may have to play a little catch up on peds, some of you, depending on what you saw or didn't see on rotations. Just know that the next class is going to have VAD and ECMO observations criteria. So you're the last graduating class that does not have VAD and ECMO observation criteria. Future perfusion students will need X amount of hours with ECMO and X amount of hours with VADs, which is actually a good thing, because VADs and ECMO are such a part of what we do. It's important that you actually see enough of that in your schooling, because someone like me didn't see any of that until I got out and as a working perfusionist. But the rotations you're going to, hopefully you see enough VAD and ECMO. And I know everybody here has seen ECMO and VADs at Christ so far. Has that kind of been part of your rotation? Not everybody?
But perhaps before the end of the semester, we all will.
Okay. So before you go out on rotations, everybody should have spent some time at Christ with ECMO patients, correct? Okay. Do you do ECMO patients here as well at Rush, or just at Christ?
Pretty much just at Christ.
Okay.
I've not had the opportunity to do any, and I've never been to Christ, so.
Okay. But Emil, is that the plan to get everybody there before rotations?
No, I don't know, but I was scheduled to go to Christ sometime this semester, so I believe.
Okay. Well, they typically always have someone on ECMO there. And for whatever reason, if you don't, and it's getting closer to your rotation time, they have ECMOs going on here at Rush. So maybe talk to Julie and I to have you go upstairs and see ECMOs here. Because it's such a part of what a perfusionist does. It's really important that you get that experience, and you're not going to be experts on it. That's okay. Being exposed to it is kind of half the battle as a student, and each time you see one, it makes more sense after that. And that's pretty much how it's going to be in general for your clinical experience. You're never going to quite feel like you're an expert, but with more repetition, with seeing more things, you get more comfortable with it. You're choosing a humbling profession. You're only as good as the last case you pumped. So I was talking about that with Mike Cotwest today. You can be a 20-year veteran, and one case can humble you. You're never at a point where everything's perfect. So each case you just be striving to do well, to learn from previous mistakes, and to constantly be learning. That's going to be a theme throughout your whole career. All right. Everybody gonna enjoy the weekend?
Can I just ask a super quick question?
Yeah.
I don't know if you've covered it, or maybe you've covered it and I missed it. Do you give much retrograde in pediatric heart surgery?
No. Have I? Yes. And again, you're talking about very small vasculature. Our smallest retrograde cannula are 6 French. So you're talking about a 6 French cannula that we can put in the coronary sinus. I've used it before, and usually when I've used it was pre-Del Nido. So before Del Nido was a thing, we had to give, if we're doing like, let's say a switch, an arterial switch, which we'll get into on the next section. But you go an extended time, once you open that root, you can't give root plegia anymore. And the ostia are so small. So oftentimes, I won't say oftentimes, but there's times where we would give retrograde cardioplegia on a switch. And you're talking about pump flows of like 20 mils per minute of the cardioplegia, where you come up just barely enough, and then you're battling high pressures because the vasculature is so small. But yes, I've given retrograde cardioplegia. It's with a 6 French coronary sinus catheter. And I would say that was all pre-Del Nido. The nice thing about Del Nido is you give that one dose and you have an extended time for them to do their repair before they have to redose or unclamp. So Del Nido has really, I think, diminished the use of retrograde cardioplegia in pediatrics, and definitely for the better, because it's not an easy thing to give.
Okay, thanks.
Sure. Any other perfusion questions or anything before we sign off?
Let me ask you a quick question about my first clinical rotation, if you have a sec when we're done.
Do you want to have a separate meeting for that, or?
Oh, it doesn't matter. I was just wondering, since my first one isn't, like, the contract's not finalized yet, kind of what your
Yeah,
plan is for LA.
we could talk about that separately. There's a couple options. That's why I have the asterisk next to your name. Asterisk next to your name means there's potential options, and clearly, I'm playing the game of, okay, it's early June. Hopefully in 2.5 months we have an executed contract and it should be no issue. But there's going to come a point where we got to make a decision, without an executed contract. But yeah, you have a couple options.
Okay.
Yeah, Dave, I mean, obviously, like, that's kind of where I wanted to go for my third site. So I was just wondering if there had been any progress at all on the LA contracts, or, I mean, North Shore as well.
I plan on giving all of the sites that are not executed yet, kind of next week of how's it going, where we at. I may or may not get information with that. Odds are, if that should be executed by the time you're going, right? So I like to think so, unless there's something totally different in terms of the legal departments not agreeing on something. I'd be fairly confident that you're going to go there. Stephanie is going to be, I'm fingers crossed for Stephanie is more of how I'm playing it. But I can't, nothing's in stone yet until we have a contract. Just, there's a lot out of my control, and trying to make the best of it. I'm glad Cedars, at least, the ball's rolling, at least with both sides, and a working document. For a while there with Cedars, nothing was going. And then Tacoma agreed, but they agreed to the last rotation.
I know, I was kind of bummed about that. I was hoping to go sooner, but I totally get it.
You'd be surprised how many sites are just not open to a totally green perfusion student coming in and learning, which is unfortunate, because honestly, it's not uncommon for students to get job offers on their first site. That doesn't mean they're the finished product. They still may not even know how to wean off the heart-lung machine, but the assumption is they're going to learn that stuff. And if they feel you're someone of good character and a hard worker and a good team player, it's not uncommon to get a job offer on your first rotation. Years back, that would be incredibly uncommon, but your generation and the state of the perfusion shortages right now, a lot of our students get offers on their first rotation. So I think the places that are not allowing students for various reasons, I think they're kind of shooting themselves in the foot, because they're missing out on potentially good candidates, because of the shortage. If you show that you're a good team player, there's places that are going to want to hire you. They're judging you more on your character than they are on your perfusion ability at that point. And ultimately, character counts, and they're assuming your perfusion ability is going to be up to par once you graduate.
Okay, cool. I just stayed on. Sorry, Stephanie. I know I didn't want to rain on your parade, but obviously with the
Good.
Evanston North Shore one, so you're just saying like with any of the contracts that are not finalized, we would just have up until, because mine, I'm like potentially the second.
Yeah,
Okay, so we would have up until that point to kind of,
yeah,
I mean,
and,
roughly.
right, and
Okay.
there's some wiggle room locally, you know,
Okay,
on that
right,
second one.
yeah,
you know, so,
absolutely.
you know, but
Yeah.
there may be a point where and let's say, for instance, I throw you at Rush
Yeah,
for the second, but then
Yeah.
2 or 3 weeks into the rotation, Evanston like gets executed,
okay.
you may go to Evanston at that point.
That's fine. I'm
Yeah.
really like flexible, even like if, Stroger Rush, I even thought like Christ, since it's the same group, whatever. So I'll be in Chicago. So wherever,
Right.
I don't really care. So yeah.
Yeah, so there's
Okay.
there's some room there.
Okay, awesome.
You're talking about a really complex Rubik's Cube that I'm trying to put together and all line up the colors right. It's so it's always
Okay,
a challenge for me.
I
but,
know. Yeah.
I can
Thank you so
imagine.
much. Yeah.
And just so you know, you're the class that got their sites the earliest. Previous record holders was the class before you. So each year I'm trying to get the sites situated a little earlier. So you got some time to make some decisions and some living arrangements. Just try to be flexible, try to roll with the punches.
All right, cool. Thanks, Dave. Have a good weekend.
All right, you too. Take care, everybody.